I'm Dr. Leslie Wakefield, a pelvic floor physical therapist, and today the hot topic is what is the difference between high-tone pelvic floor dysfunction versus vaginismus? Because I'm seeing patients coming in either misdiagnosed by their physicians or having sort of diagnosed themselves but not understanding the difference. I'm also seeing a lot of patients with overlap. They have both. And I know that a diagnosis is just a label. I preach that all the time. It's just a name for what you're experiencing. It can't encompass the uniqueness of every person's expression of that diagnosis. But in this case, I do think it's important to understand the difference because there is a difference in the way you treat those conditions. And certainly there is overlap in the treatment strategies depending on the person. There's often overlap of those two diagnoses, but they're two separate categories that I want to talk about. I did put together a self-assessment quiz for this subject just to make it sort of easy to interact with, and I'm going to include the link to that on the replay. This replay will be posted on Facebook and on YouTube, and you can find the self-assessment quiz to help you determine, do you fall more into the high tone category or the vaginismus category, or potentially an overlap of both. So I thought we would divide up the discussion into three parts. What is each diagnosis? Why does each one occur? What might be some of the precipitating factors? And then how does treatment differ? And then again, if you find yourself wondering, where do I fall in that spectrum, check out the quiz. Obviously, it's not diagnostic, but it'll give you a sense of where you fall more, which category you fall more into, so that you can help advocate for yourself, seek out the right therapist, guide your own treatment. So high-tone pelvic floor dysfunction is when the muscles are generally gripping. They're generally tight. And we're talking about the pelvic floor muscles, just in case anyone's not sure what that means. We're talking, this is a female pelvis. We're talking about these muscles. Everything you see in red here is pelvic floor muscle. And in the case of high tone, what that means, it's high tension. High tension is actually the correct way to name it, but high tone is more common. So it's when these muscles are gripped and holding. And you can liken this to somebody that clenches their teeth habitually. Their jaw muscles are just kind of constantly gripped. Or there's some people and they walk around with their ears around their shoulders. They don't realize they're doing it. It's a habit. It's actually an inappropriate set point of the muscle, so that the muscle thinks that it's in neutral, but actually it's holding this extra tension. And for someone with high tone pelvic floor muscle dysfunction, this can generate symptoms because those muscles are overworking. The function of those muscles in general should be to help control pee, poo, sexual function, and postural support and breathing. So for someone who's gripping, the first symptom that tends to pop up is pain, and that's where people notice it. They might also show urinary issues like urgency or frequency. They might have problems pooping with defecation. It might present as constipation. There might be painful sex, whether it's touch to the outside or penetrative sex. They might actually have this high tone because one of those other pre-existing problems. So if you have pelvic pain or you have pain in general in that area, the muscles will try and clench and grip because it hurts, and they're tense and they're anxious muscles, they're painful muscles. So I'm getting distracted because there's actually somebody watching right now live. I'm so excited. Hi. I don't know who you are, but welcome. There's never anybody watching. I always just record it and put it up later. So high-tone pelvic floor dysfunction is when the muscles are generally, oh, they left. I scared them away. It's okay. It's when the muscles are generally gripped. They have this inappropriate set point. It can generate pain, and it can lead to functional issues having to do with bladder, bowel, sexual function. Very generally. Vaginismus. What is vaginismus and how is that different? Vaginismus is a reflexive gripping. It's a sudden spasm. It's in response to attempted penetration. So this is different from high-tone pelvic floor dysfunction, where those muscles are always kind of tight and grabbed and inappropriately tense. In vaginismus, this person might walk around relaxed normally, but when penetration is imminent, those muscles go into a protective spasm. And I've heard this likened to a panic attack of the pelvic floor muscles, and I think that's very appropriate. Or sometimes I'll call it a Charlie horse of the pelvic floor muscles. And this spasm, it's intense. I mean, they feel the spasm occurring, although not always. And it can even include the thigh muscles might start shaking, the abdominal muscles might start shaking. It might actually impact breath. And it is often and usually associated with a high level of emotional distress as well. A sense of aversion, of very specific fear and anxiety and wanting to avoid that stimulus. So high tone pelvic floor dysfunction is a chronic high level of tension in the pelvic floor muscles. It's an inappropriate general set point that's usually presenting, and it can get worse or can get better depending on different scenarios. If it's being caused by pain, if the pain gets better, a lot of times the gripping gets better. If it's related to a high level of kind of generalized anxiety, if the person, for example, took a Valium or did something else to relax, then yes, that tone might decrease. But in general, it's a chronic gripping of the pelvic floor versus vaginismus, which is a very spastic, reactive Charlie horse that occurs when penetration is attempted. Let's talk about then, if you're starting to see maybe yourself in one group or the other, let's take a step back and see why might some of these happen. We touched on a little bit, but you also might find yourself in one category or the other. So for high tone pelvic floor dysfunction, I mean, every person is different, but a lot of times we'll see that in a person who does have very high levels of chronic stress in their day-to-day life. So they're the person that might have their shoulders around their ears because they're just so tense at work all the time, or they might be gripping their jaw because they have high levels of stress, or they're doing all of these things potentially, or they might be gripping their pelvic floor as a way for their body to sort of express this tension and this stress. We also see it in people who have chronic pelvic pain conditions or other chronic pain conditions. So for someone with, for example, interstitial cystitis, which is a bladder pain syndrome, or someone with endometriosis. So there's this chronic inflammatory pain going on in the pelvis, and so these muscles are gripping and tense because they're surrounding a painful place. People with chronic incontinence, whether it's because of, for example, after a prostate surgery, men who have their prostates removed, male bodies who have their prostates removed, who then have chronic leaking or are worried about chronic leaking, will also often start to grip their pelvic floors subconsciously, trying to control urine. Someone who has a little bit of prolapse, who's chronically worried about leaking, might also be gripping their pelvic floor chronically and subconsciously, trying to control urine. People who wear abdominal supports, not even supports, but sort of aesthetic binders, and are always sucking in their tummies, trying to keep their tummies flat, this will generate increased tension in the pelvic floor because the abdominal muscles in the pelvic floor are really tied together neurologically. So if you're always gripping other muscles in that area, either knowingly or unknowingly, if you're overtraining in your exercise routine, or you're doing something like classical ballet or classical Pilates that requires a lot of hold, grip, lift all the time, this can develop patterns of gripping in the pelvic floor that become this new set point. What about vaginismus? Vaginismus is often, but not always, associated with some sort of traumatic event at the pelvic floor, at the vaginal opening, that resulted in potentially pain with penetration. And that can fall into so many categories. The first thing that comes to mind is, there must have been sexual abuse. And sometimes, unfortunately, there is. That is true. But not always. That is not every woman with vaginismus. Certainly there are cases of sexual trauma, sexual abuse, unwanted touch, even emotional anxiety around an anticipated assault That can absolutely lead to the spasm of the pelvic floor when penetration is attempted later. But other things, so for example, if a woman hits menopause and her skin changes and then sex becomes painful, and over time her body learns to fear sexual contact because in experience it is painful, or if there's an infection that happens, or potentially if someone grows up with sort of cultural ideas around purity culture or modesty or shame associated with sexuality, there could be a lot of underlying issues. Occasionally I certainly do have people that say, I couldn't even begin to guess why this is happening. I'm telling you honestly, I don't know why. I don't have trauma. I didn't grow up in shame culture. This is just what my body is doing. And that's okay too. There doesn't have to be this thing that you know is causing it. But a lot of times we can sort of weed out, and especially working with a counselor or a sex therapist can also help to weed out maybe some of those underlying issues, whether they were medical, traumatic, cultural, or emotional. But a lot of times, although not always, there is this preceding event or idea that then results over time in vaginismus, this clamping down, reflexive gripping of the pelvic floor that either prevents penetration completely or makes it really uncomfortable. And there are women with different triggers. So for example, some women can absolutely tolerate going to the gynecologist, but can't or don't want to involve in partner sex that's penetrative. So that has a lot of different presentations. So then let's get myself organized and on track. We talked about what are the two different diagnoses. What could potentially be preceding each of those to maybe cause that diagnosis in the first place. Now let's talk about treatment, because the treatment, while there can be overlap of treatment, a lot of times we tailor it differently depending on the diagnosis. For someone with high tone pelvic floor dysfunction or high tension pelvic floor dysfunction, we are going to be taking a very global, at least in our practice, a very global approach. It's a zoom in and zoom out. We're doing a lot of stretching for the hips and the abdominal muscles. We're doing a lot of postural work because we did talk about, if all these other muscles are gripping, the pelvic floor tends to grip also. So we want to try and unwind all of those body patterns. So we do postural work. We do a lot of hip and core stretching. We do a lot of breathing because the respiratory diaphragm, which is your primary muscle of respiration, it's very tied to pelvic floor function. So we want to normalize a breathing pattern so that the pelvic floor can then normalize its tension. We will also do something called down training of the pelvic floor muscles, which is re-educating those muscles where their true neutral set point is. They're confused. They think their set point's up here. We want to re-educate. We want to down train so that they learn their set point is actually right here at a more neutral level. And that takes a lot of different forms. We can use different forms of biofeedback, whether that's electrical biofeedback, like the EMG biofeedback, whether it's self-palpation, whether it's feedback from the therapist or using a mirror. We use manual treatments directly to the pelvic floor if that's appropriate, and that can be done on the outside or the inside. And we can also teach patients how to do that at home using a treatment wand. So that for high tone pelvic floor dysfunction, at least in our practice, there's a zoom in and a zoom out approach. We want to directly treat the pelvic floor muscles to help them relax and learn how to stay relaxed, to release any fascial restrictions that may have developed over time or trigger points that may have developed over time. And this zoom out approach to make sure that the rest of the body is helping the pelvic floor to relax, that we've got our posture and our breathing and all the other accessory muscles in order. For vaginismus, we might also be doing some of those things. Some of those things might still be appropriate. Good posture is still going to be appropriate. Good breathing is still going to help the pelvic floor release. 100% of the time, I want my vaginismus patients doing these really good hip, core, and pelvic floor stretches. But the focus of treatment, at least in our practice, is a little bit different, and it's more about desensitizing the reactivity of the pelvic floor muscles. Because the pelvic floor muscles, in a case of true pure vaginismus, they're not running tight all the time. The problem is that they are reactive to stimulus. They are perceiving or anticipating that any type of touch or penetrative stimulus is going to be painful or problematic. And so they have this reaction. It's not on purpose, it's completely outside of the person's control. It's this nervous system reaction that occurs that results in spasm. So we want to desensitize that reaction. We want to re-educate the muscles, yes, but this time in a different way. Not like high tone pelvic floor dysfunction where we're re-educating their set point to be lower. In this case, for vaginismus, we want to re-educate the muscles that the stimulus is not dangerous. That stimulus does not have to be painful. And so we're re-educating them also, but desensitizing to touch versus down-training global tension. Okay? And now what if you're a combination of both? And we see that a lot, actually, because it's very understandable for someone to, let's say, have high tone because of interstitial cystitis or endometriosis or some other pain condition. Sex becomes painful. They perceive sex as painful repetitively. The muscles learn to anticipate pain and will start to generate, in addition to their original high tone, this reflexive spasm. That would be a really typical case of potentially seeing both diagnoses together. On the other hand, you might have someone, for example, with a history of trauma, and they do have vaginismus in part as a result of that trauma, or in full in part of that as a result of that trauma. They might also be in general tense, anxious, depressed. That's normal. That's understandable. That might be part of the full picture that needs treatment in that person. And because they are generally running tense, anxious, depressed, whatever that situation is, they might have global high tone. They might still have that clenching of the teeth. They might have the gripping of the pelvic floor. So even though potentially their primary or original diagnosis is vaginismus, they also have developed general high tone dysfunction of the pelvic floor. There's so many different ways that these two diagnoses could overlap, but I do think it's important to differentiate that they are two separate diagnoses that can be coexisting. And when we evaluate and treat, we want to make sure that we're evaluating effectively to treat the right condition, to tailor treatment for the right person. Because if you have someone with vaginismus and their primary issue or their larger issue is this reactivity of the pelvic floor, it is not going to be helpful to go in and try and do internal manual massage there. That might make it worse because we're trying to introduce penetration, which would not be appropriate at that time for that person. We might first need to desensitize the reactivity of the pelvic floor muscles with vaginismus, and then potentially later be able to engage with the high tone and work on some of those other manual techniques. Or potentially we address high tone using some of the more zoom out techniques that we talked about earlier, while working more zoom in on the vaginismus and desensitizing the reactivity. I hope that makes sense. I do, one more time to remind, I do have that self-assessment quiz that I'm going to include in the description of the video. It is a tool not to diagnose yourself, but to help see yourself, which category do you fall more into, or potentially are you showing more of an overlap of both. And you can fill out that quiz and take it to your treating physician or your therapist, or just use it to guide your own self-treatment. But find it in the show notes, download it. Let me know if you feel like something is missing, or if your story's a little bit different and you'd like to share that. We can talk about it next week. As always, please like and follow. I love feedback. I love to hear from you guys. See you next week.